Welcome everyone to our Time for Genetics webinar. We're just giving everybody just a few minutes to join here from the waiting room. But we are very excited for our event today, and we're so glad you are all here. Today's webinar will be on the topic of red flags for genetics. So if that's what you signed up for, you are in the right spot, and we'll do some introductions here in just a moment of our speakers. In the meantime, if you could put your phones on mute and your computers on mute to preserve the sound quality. We will be recording the presentation today. Some of our clinics and invitees weren't able to make it due to patients, seeing patients, so we want to provide the recording for them as well. With that, I'll get up our next slide here, and we'll go ahead and get started. So we'll start off with our HRSA funding statement. Mountain States Regional Genetics Network is funded by support from the Health Resources Service Administration of the U.S. Department of Health and Human Services. If you would like more information about this funding, you can visit hrsa.gov. And just a quick introduction, my name is Christy Weiss. I'm the projects manager for Mountain States Regional Genetics Network. And today we also have on Cody Price, our projects coordinator. And please feel free to reach out to either of us in the chat during the presentation. If you have technical difficulties or have any questions, you can find us. Our names start with MSRGN, so you can find us easily on the attendee or participant list. And just a couple of Zoom logistics. I know this is kind of old hat for some of us, but some might be new to this, so we just want to review. At the bottom of your screen, you should see some controls. The number 1 is the mute and the unmute button. We are asking everyone to stay on mute during the webinar, again, to preserve the sound quality. For number 2, we are asking you to feel free to keep your cameras on or turn your cameras on if you would like to. Just to note, though, we are recording the call for archival purposes, so if you don't feel comfortable having that possibly recorded, your image possibly recorded, then please turn your camera off using the video, stop video there at number 2. Number 3, you can find our participant list and who is actively online with the call. And number 4, we're going to use the chat feature for questions, answers, or technical issues, as I mentioned. You can chat to Cody and I specifically, or you can chat to everyone with your questions. So you can find that at number 4. And I just wanted to let everybody know who might not be familiar what our Time for Genetics program is all about. So Mountain States Regional Genetics Network is an 8-state region. You can see by the map here, those are the 8 states in our region. And with our federal funding, we have launched a program called Time for Genetics. It is a pediatric primary care genetics education initiative in our 8-state region. In last fall, we worked with our state teams to recruit 7 different clinics across our region, and they are our first cohort. Some of them have joined us today, and we welcome them. They're our first cohort in this program. In this coming fall of 2021, we will be opening up spots for our cohort number 2 of primary care and pediatric clinics. So if you or someone you know might be interested in participating in that second cohort, please message us through our page, our website page there, which is mountainstatesgenetics.org/T4info. And that has a video about the Time for Genetics initiative and a 1-pager and a link to contact us. So that's the page. You can find out a lot more information about our Time for Genetics initiative. With that, I'm going to introduce our speakers. We are thrilled to have with us our guest speaker, Dr. Carrie Schmid. She's been caring for infants and children and adults with genetic conditions since 2007. She has provided medical care around the world, serving as a clinical geneticist and pediatrician for the United States Air Force, as well as a group practice in San Antonio before joining the genetics team at the Children's Hospital of San Antonio. She completed her pediatric residency at San Antonio Uniformed Services Health Education Consortium in 2005 and completed her clinical genetics training at Harvard Medical School in 2007. Thank you so much for being here, Carrie. And I'll also go ahead and introduce Alexandra Grace. Alexandra received her Master's of Nursing from the University of Texas Health Science Center at San Antonio, with a focus in clinical training in metabolic and clinical genetics at the Children's Hospital of San Antonio and Dell Children's Hospital. She previously worked as a metabolic nurse and assisted in early reporting and management of patients identified through the Texas Newborn Screening Program. And she is passionate about newborn screening, metabolic conditions, and molecular genetics. Alexandra is a board certified pediatric nurse practitioner who joined the genetics team at the Children's Hospital of San Antonio in January 2020. Welcome, Alexandra Grace, and thank you for being here. And with that, I'm going to turn it over to our speakers to get started with the Red Flags for Genetics webinar. Thank you again for being here.
Thank you, Christy, for that kind introduction. As she said, my name is Carrie Schmid, and it's my pleasure to speak with you today. Both Alex and I have a passion for helping the primary care provider to recognize genetic conditions and to hopefully refer when you feel it's appropriate. All right. The objectives today were, we wanted to define genetic red flags and then identify historical findings, physical findings, and lab features that should raise a flag for you. We wanted to review genetic referral indications and thereby empower you to confidently refer to your local genetics provider. But first, we have to start with asking the question, why do you want to recognize genetics in your very busy pediatric clinic? Well, understanding a patient's predisposition to a health condition based on their historical or clinical details will improve prevention or start early treatment. Genetic testing is rapidly advancing. We now have direct-to-consumer genetic testing, so patients are going to come to you with questions and they're going to expect that you have a good understanding of genetics and genetic testing. And so in order to help you, referral to a genetic specialist will allow for us to help patients select appropriate tests. We can counsel on risks and benefits of testing, proceed with recurrence risk counseling, and development of a surveillance and treatment plan, ultimately moving towards what is called personalized medicine. Well, what is a red flag? Most of us have been to the beach and have seen this posted, so we know it's a warning sign. In clinical genetics, a red flag would be a finding that you discover on history, exam, or lab studies that suggest there's a presence of a genetically influenced disease. This discovery may require further actions such as referral, counseling, screening, and long-term monitoring.
Oh, Alexandra, you're on mute.
So sorry, rookie mistake there. I wanted to start with a comical story I wanted to share about the feeling of coming into genetics blind. When I was an NP student, I attended a genetics residency, as previously mentioned, where I was asked to see patients independently and then report my findings. I vividly recall a certain patient with referral indication of delayed dental eruption. I remember eagerly presenting my findings and history to the attending provider, who later asked me about the appearance of the eyebrows. Let me just say, I stammered hopelessly to produce an intelligible response, but was utterly dumbfounded. When I returned to the patient's room, I realized they didn't have any. I was later told that the patient had ectodermal dysplasia. Thanks. Which brings me to how can the primary care provider navigate through the all too famous 15-minute well child exam with the tools necessary to detect diseases and all risks for disease? So I hope you don't mind a little fun today. For those of you that have played those escape the room games, this is going to be a little bit like that, but a modified version. As this does have a chat box, you're welcome to add some input or ask some questions as we go through this. But essentially, we are going to go through the 15-minute exam and see what happens in the end in our assessment and plan.
So, Mrs. Grace, Luke is ready for you to visit. He's usually seen by your partner. He's here for his 9-month well visit. His mom does not have any concerns. He has no new medical history or medications. And by the way, don't forget, we have our going away lunch starting in 20 minutes.
Classic. All right, ready. So I think this may or may not be close to what your EHR is going to look like. And essentially, you're going to quickly review before you see your patient. You already feel the time crunch. And looking in your past medical history tab, you see that this patient has a history of feeding difficulties, some developmental delay, and congenital heart disease. In quickly reviewing their social history, you see that your patient Luke lives with his mom, he attends daycare, and there aren't any exposures or concerns for abuse. The family history has just a few items. The mom has what's called, or something about a heart problem. She has some learning difficulties. And then her mother also has some learning difficulties, and she required some kind of surgery for her eye. So you scroll on over to his vital signs, and it looks to be that Luke might be on the small side. His height is around the 2nd percentile, as well as his weight, and his head circumference is on the growth curve at around 10 to 25 percentile. So you get ready for your exam, and we're just going to presume that looking at his tympanic membranes and all the other items of his face, head, and neck are normal. And we're just going to observe Luke. So when we observe Luke, we notice that there are some differences that may or may not come out or strike you. We do notice that his forehead is tall, his palpebral fissures are down slanting, and his right eye is slightly more closed than his left. He has right eye ptosis. We also notice that his ears are posteriorly rotated, or they appear to be more low set. You can't really appreciate it in this picture, but Luke does have a short neck or a webbed neck. He has a low posterior hairline. So I don't know about you guys, but this often happens with me. I'll go to undress the baby and bammo, there's a sternotomy scar. So this happens to be the case. And you also notice that he has some widely spaced nipples. So you bring this to the attention of the mother, you say, oh, looks like he had a surgery. And she pulls an echo out of her purse. And it demonstrates the following findings. He has a history of septal hypertrophy, severe pulmonic valve stenosis, status post-repair, and an ASD. So in evaluating Luke, when you go to do the GU exam, You note that his testicles are undescended and his penis is small. This is typically for me the time that I go to play with my babies. So I'm playing with Luke, and maybe I didn't notice before, but he has SMOs. So I come to find that his joints are lax, maybe he has some elbow joint laxity or his fingers. He has a history of persistent head lag, and in the exam, I'm noticing some signs of hypotonia like diastasis recti, and that his feet are a little pudgy. In doing the skin exam, I noted that he had multiple cafe au laits and nevi. And I reflect back on his picture before, his hair is very sparse. So that was a pretty quick exam. We're at about 5 minutes, and we're just going to estimate that we've had the time to sort of talk about these things with the mom. So in review, the items that I would chiefly review with the mom in the visit today would be Luke's size. So I would talk to her about his short stature, maybe get some more information about the family history. I would point out that he is underweight, talk to her a little bit about his diet. Is he still on formula, or is he eating? Does he have any swallowing problems? I recognize that his head is actually relatively large to the size of his body. I may point out some of the features in the exam that I noticed that were a little bit different with the mom. He does have some dysmorphic features that struck me in the exam. So I may bring that up or ask her, who does she think that Luke looks like in the family, and kind of gauge her perception of if something is going on different with Luke. Then I'm going to talk to her about his undescended testicles and explain that I feel that that may be actionable, and that we're going to need to do some referrals and some follow-up on the items that we identified today. So we're at about 7 minutes, and we're going to be formulating our assessment and plan, because you remember, you got to do your charting. And so as I start to process what I talked to the mom about, I'm going to, of course, in this well-child exam, alert the nurse that we're going to need to get him up to date on his vaccinations and provide regular anticipatory guidance for an 8-month-old. I'm going to give mom some labs to get completed today, some screening labs for his size, such as looking at his thyroid, his growth hormone, get a CBC. And given his developmental delay history, I'm going to make sure that he's tapped into ECI and that he's getting services. He's going to need a referral to ophthalmology given his ptosis, and also to urology for his undescended testicles. And I'm going to make sure that he has a cardiologist and that he's following up regularly. Mom has that information. And then we're going to do a referral to genetics.
So I have the opportunities to see Luke in clinic, and my impression is that he is a 9-month-old infant male with facial features, congenital heart disease, cryptorchidism, and hypotonia that is consistent with a clinical diagnosis of Noonan syndrome. I went ahead and recommended genetic testing, and there are now several genes associated with Noonan syndrome, so I select a gene panel. This panel returns with a positive DNA finding on the PTPN11 gene. And because this is an autosomal dominant condition, I offer parental testing, and it turns out that mom is also affected. So again, he has a clinical and molecular diagnosis of Noonan syndrome. And with his visit to the genetic clinic, we're able to provide counseling on autosomal dominant inheritance, and then also to provide feedback to you as the primary provider about expected surveillance and therapies, specific growth charts for his medical condition, and also the guidelines that have been published.
So hopefully through this exercise or game, we reviewed that you don't have to know everything about genetics. And as Dr. Schmid and I both come from some background where we've had some primary care experience, we both know that 15-minute exam well, and the pressures that come along with it, and all the things that you have to cover within the well child exam. So hopefully, given the brief review of some things that we pick up on, we can cover in these next slides some useful tools that you can use in your next exams. So one of the tools that we're going to be going over today is actually going to be an adapted tool that was created by Dr. Grix, and it's the rule of two, the rule of two. So the rule of two goes something like this. This basically summarizes it. When you're evaluating a child, you can go over just what we went over. So to see if they're too tall or too small, you start to look at their family history and the appearance of certain things, either in the patient or in their family members. And you start to evaluate the other things that may not be apparent in your exam, such as in the case of Luke, looking at his echocardiogram and congenital heart defects.
So I would like to talk a little bit about what does it mean to be too tall. Oftentimes, patients who are tall in stature are not necessarily thought to have a medical issue, but there are certain genetic conditions where you are, quote, too tall, and we need to address any sort of comorbidities that would come along. So too tall is defined as a height above the 97th percentile for your age and your gender, or more than 2 standard deviations above the mean. What you can see in these photos is a young adolescent female who is tall, as you can see by the height of the examiner. And what the examiner does in response to finding that she is too tall, she measures her arm span. Now, this would not necessarily be done in a primary clinic, but this is something we would do in the genetics clinic to see if our patient has proportionate or disproportionate tall stature. And then on the box where you see the hand, this is a perfect example of what is called the wrist and the thumb sign. So this patient is demonstrating that he has long fingers, which is called arachnodactyly. And what you can see for his thumb is that it fully extends beyond the ulnar border. And then for the wrist sign, at the smallest part of his wrist, he is able to overlap his 5th and 1st digits. This is in particular a sign for Marfan syndrome. However, there are other medical conditions, genetic conditions that will present with tall stature that might need to be further evaluated, including Fragile X syndrome or homocystinuria. Well, on the opposite side would be our patient who is too small. And too small would be a height below the 2nd percentile for age and gender, or less than 2 standard deviations below the mean. The first picture demonstrates a 2-year-old male who is showing us that he has some disproportionate short stature. And what we mean by disproportionate is that when we measure his legs or his lower segment and compare it to his upper segment, we will find that his extremities are shorter than expected for the length of his torso. And you can see in this photo that the upper part of his arm is shorter than expected, and we call that rhizomelia. And then you can also see that in the femurs. And then you can see that he has bowing of his tibia. The middle picture is of a lovely little girl. And if we do her upper segment and lower segment measurements, we actually will find that she is proportionate, but still much below the growth curve. In fact, she started below the growth curve. She had small for gestational age. She has relative macrocephaly, so her head size is preserved. And you can see that in the photo. She's got a very prominent forehead. And if we turned her to the side, we might see frontal bossing. And so for my little guy who has disproportionate short stature, this is a picture of hypochondroplasia, which is a skeletal dysplasia. And the little girl is proportionate short stature, and she has Silver-Russell syndrome. And then on the growth chart, you'll just see where their growth parameters would lie and how they are very much below the 3rd percentile. Next in the rules would be something that appears to be happening too early for your patient or too early for the family. So an example would be a cerebral vascular accident in your adolescent patient. And you would want to make sure that in the hospital they had their thrombophilia evaluation. And then if there are results, did they receive genetic counseling for those results? Another example will be your infant who comes in having failed the newborn hearing screen, who is being followed for congenital sensory neural hearing loss. In the developed countries, greater than 80% of patients with congenital hearing loss will have a genetic cause. Another clue might be vision loss by the age of 20. They might on ophthalmology exam have retinitis pigmentosa, and we would certainly want to provide genetic counseling as needed. Another thing that happens too early in some families would be sudden death for unknown reasons. And so in genetics, we like to explore that a little bit in a little bit more detail. And then finally, if your patient's mother is sitting across from you and shares with you that she is starting treatment for breast cancer, and you know she is only 35 years of age, that's a red flag that this family needs to be seen in genetics. Well, you can have too many of something. And so anytime you see more than 6 of something, as these pictures are demonstrating, we would encourage you to think a little bit about what else might be going on and to consider talking to your genetics colleagues. What you see on the skin are cafe au lait macules. And then what you see in the photograph of the hands and feet are extra digits on all 4. In addition to having too many cutaneous findings, you might have in the history too many fractures. You might have a history of too many specialists. So if your patient is seeing multiple specialists, and it's not necessarily for an infectious or rheumatologic or hematologic reason, you might consider a geneticist as part of their team. And then too many infections. Is it time to start evaluating for primary immunodeficiency? And that is very often a genetic evaluation. Well, this is a little bit difficult. How do you figure out if something is too different? I think it is just a gut sense or your background and how many children and families you have evaluated. So when you have a healthy child at the 11 to 12 year well visit and you perform the screening cholesterol and the LDL returns incredibly elevated, it's time to ask, is there any history in the family of early heart attacks or parents who are on cholesterol lowering medications? Because this is an autosomal dominant condition, and even though the child appears healthy, we're going to need to help the family through this disorder and treat them sooner rather than later. Does your newborn baby in the office have an abnormal newborn screen? There are a lot of protocols that are in place, but just as a reminder, we definitely want to hear about these children sooner rather than later. For our children with global developmental delays, and that is, children who have 2 or more developmental domains that are abnormal, oftentimes this is a precursor or a predictor for intellectual disability. And so we would love to see these children sooner rather than later. And in fact, what we are finding for our children who have intellectual disability is if they are non-syndromic, there is still a chance we will find a genetic cause. And it is being estimated that with all of our newest, latest and greatest testing, 50 to 80% of children with intellectual disability will have a genetic cause. Back to growth parameters. So we are concerned if the head is too small or the head is too big. Certainly there are benign familial large heads and benign familial small heads. But if you're finding anything else in their history with regards to a developmental delay or minor features on exam that are different, I would encourage referral. When you have a young boy who is delayed in his gross motor skills, especially if the parents are concerned because he is toe walking, or on a physical exam, you notice that his calves are bigger than you would expect, so muscular hypertrophy. It's very important for us to meet this child and to help him quickly. Sometimes you will meet patients whose skin seems too stretchy, too velvety, too thin, or just scars really significantly. This might be an indicator for a connective tissue disorder, and we oftentimes evaluate these patients and assist with their diagnosis and care. And then, as Alex mentioned on her earlier scenario, a child with no hair or decreased number of teeth, that can be a red flag for a genetic condition that we need to further evaluate.
We wanted to just spend a little bit of time to highlight on this slide the power of getting a CK. We frequently get patients in the genetics clinic for various reasons, including, as Dr. Schmid had mentioned, developmental delay. We also get kids into the clinic for elevated liver enzymes or hepatosplenomegaly. Often this lab is left out, and it can be quite invaluable to putting into perspective, is the liver actually sick or could muscle disease be going on? So we just wanted to send an encourager out there that if you have a child that has these things going on, to go ahead and get a CK.
So moving back to the rule of 2, a family history or a personal history of 2 tumors can be of concern. And so that could be 2 primary sites of cancer, such as a bilateral breast cancer or a bilateral retinoblastoma or bilateral schwannomas. Those all would raise a red flag for us in genetics to do some further investigation. Or if a person has 2 types of tumors, such as breast and ovarian cancer, medullary thyroid carcinoma, and a pheochromocytoma, or a follicular thyroid cancer and breast cancer. So 2 tumors is of concern.
So we wanted to focus a bit on the family history. We recognize in the well-child exam, you don't necessarily have the time to draw a full-blown pedigree, but there's some clues that you can get in the exam from what patients tell you to start to investigate that further to see if maybe something genetic is going on. We listed some conditions at the bottom just as ideas of things that often are discovered simply by doing a family history.
Alexandra, we're losing you a little bit on your audio.
Is it cutting in and out, or is it not working?
It's cutting in and out. So if you could maybe just repeat that last slide, we caught about half of it.
Oh, I apologize for that. Does it sound better now, or?
It
Is
does
it
on
still-
my end. Thank you.
Okay. So we just wanted to spend a little bit of time to also review family history. We recognize that in the primary care clinic, there isn't necessarily time to draw a full-blown pedigree, but often what patients tell you can offer a clue that maybe something genetic is going on. And one of those clues is quite possibly there's 2 generations affected with similar symptoms, such as in the conditions listed below, but of course there's many more. So we wanted to give some examples of what patients say and then sort of what ends up happening or the outcome. So something that we get a lot is we'll be evaluating a child and dad will, in his history, he'll say, oh, I have really high blood pressure. Funny thing though, my brother is on dialysis and he also has high blood pressure. And then the grandfather or the dad's father, he was a recipient of a kidney transplant. So a history such as this may be indicative of something such as an autosomal dominant kidney disease. So at that juncture, it would be good to check the child's blood pressure, ask more questions about the age of onset in the father, the uncle, and the grandfather. And they may even know what their diagnosis is.
So another example that we have seen is a patient comes in for further evaluation of a family history of arrhythmias, and mother will tell us that she is being further evaluated by her cardiologist. She's not quite sure what her arrhythmia is, but she is being followed and they're in the process of evaluating. Unfortunately, her sister passed away young, and that was in a drowning accident. And then her father also has an arrhythmia and has an implantable defibrillator. So what we would think about and be concerned about is an autosomal dominant arrhythmia syndrome like long QT syndrome. And we would encourage an EKG sooner rather than later. And then again, just asking the patient a little bit more about onset and if there is a known specific diagnosis. And then just one more example of a family history that might not necessarily initially raise a flag for you, but it does raise a flag for us in genetics. And so potentially this family arrives to the genetics clinic because of a child who has a large head and has developmental delays. But when we take the family history, we see that mom is tall and has a history of thyroid cancer. We learn that sister has autism and also has a large head. We learn that mom's brother is tall and also has autism. And then that her mother has had problems with benign breast disease and has a history of thyroid cancer. And so again, this is showing that in 2 generations or more, we are seeing a pattern. And this is a pattern consistent with P10 related syndromes. And it would be important to check your patient's head size. It's always important to measure a mother's head size and a father's head size if the child's head is large, seeing if it comes from the family. Reviewing your patient's developmental milestones, particularly if they're older and already in the elementary school. Perhaps you didn't know the history that he was globally delayed as a younger child. And then of course, I guess what we've said 2 or 3 times now, go ahead and ask about age of onset for cancers and if there is a known diagnosis in the family.
So we also wanted to highlight the 2 in the family. So like what we've mentioned before about 2 generations, there might also be a history of 2 siblings or 2 uncles. That may be a sign of an autosomal recessive condition. And so frequently what we may encounter in the genetics clinic is there's 2 siblings with PKU, for instance. So this would be an example of a pedigree of what we would collect in the genetics clinic that just gives us a quick synopsis of, oh, I think this might be running in the family.
And then, of course, as we learn about the family effects and who is affected in the family, we can provide better genetic counseling with regards to recurrence risk and how to help families perform surveillance. So the final 2 in the rule of 2 is 2 birth defects. So birth defects is just as it sounds. These are anomalies that are found anywhere in the body that will affect structure and function. And as noted, because they're at birth, they are of prenatal origin. We divide these into major and minor, and major anomalies are going to be those that have a significant consequence and usually require medical intervention, whereas minor may be of no significant health issues, but just something we see that is different from other children. 3% of newborns have a major anomaly or major birth defect, but by the time you're 5 years old, it's a 5 to 7% chance of having a birth defect discovered. And so this is just an example of what major anomalies would include, but those are your neural tube defects, your microcephaly, your small ears or absent ears, clefting of the face and palate, defects in the abdominal wall, genitalia abnormalities, or limb abnormalities, including club foot. It will, of course, include your congenital heart defects and other atresias and stenosis that have to be taken care of. Your minor anomalies are more common, and up to 15% of newborns will have a single anomaly. However, the more minor anomalies you see on physical exam, the higher that flag should go for looking closer at this infant and seeing if there are other findings that need further intervention. Because by the time you get to 3 or more minor anomalies, there's a higher chance of having a major anomaly. So these would be the patients where I would do a great heart exam and then also order a kidney ultrasound and maybe a vertebral x-ray if I need to look for further anomalies. Interestingly, for children who have global developmental delays and intellectual disability, 40% of them have 3 or more minor anomalies. So again, a red flag is the more you see, the more likelihood there is that there's something in their genetic code book that we could potentially find. And so this is a basic list of minor anomalies. It would include those preauricular tags, extra nipples. It might include a coloboma of the eye, or on the palm, the single palmar crease. But many of these things don't necessarily have to have interventions. And so therefore they are minor anomalies.
So in summary, we reviewed the tool of 2 and 2. We hope that this can help quickly screen patients that may need a referral to genetics or showing some red flags for genetics, or a prompt, a more comprehensive evaluation.
And then if you would like even more understanding of indications for genetic referral, it's not quite as easy to remember, but the American Academy of, or the American College of Medical Genetics in 2007 published a guide for health providers on when to refer to genetics. And we've addressed several of these today because we've used the rule of two. But please note that congenital hypotonia or hypertonia, especially in combination with dysmorphic facial features, metabolic disorders, failure to thrive, or other things like autism may very well be a good reason to refer to genetics. So in summary, we think that you guys have a wonderful opportunity to identify genetic red flags. And these flags should prompt you to consider further evaluation. And using the rule of twos, you can see that multiples in a patient's history or a patient's examination or a patient's family history will raise your flag for referral. We recognize in our large area that genetic providers are few and far between. And so the expectation is that it will take months to get in to see your specialist. And so we would encourage you to call, to reach out to your referral clinic, or you can contact our hospital and ask to speak to one of us, because we would love to help you consider evaluations to do in the interval time, as well as help understand if it's more of an urgent referral. So please reach out with questions and concerns. We have a little bit of time, and so these are some resources that I think are wonderful for geneticists, but also for primary care providers. And so the group we are a part of today has a page set up already for the primary care clinician. And so it has a lot of wonderful resources. ACMG is the American College of Medical Genetics. And this is where you're going to find ACT sheets. So the ACT sheets are what your newborn screening coordinator for your state may send when you have an abnormal newborn screen. And they provide basic information on the medical condition and what the expected evaluation and workup should include. The National Society of Genetic Counselors is a great resource in understanding how we care for our patients with genetic predispositions and genetic conditions, and how to get a hold of a genetic counselor. And then the rest of the resources are places you can go to understand your patient's medical condition a little bit better. And so the National Organization for Rare Disorders, online Mendelian Inheritance in Man, Gene Reviews is wonderful. And then the Genetic Home Reference is now Medline Plus, but it has patient-friendly written materials that will discuss genetic conditions, as well as inheritance, and give resources for families. Of course, the American Academy of Pediatrics has a lot of publications, especially for particular genetic conditions. There might already be guidelines for how we treat these people, and may even have special growth charts for them. And then if you want CME, there is education through the Jackson Laboratory, and it's free of charge, but you can go through and earn some CME, learning more about our current state of genetics, genetic testing, and how to care for your patients. So that concludes our presentation, and we would love to answer questions.
Thank you so much, Carrie and Alexandra. We really appreciate all of this information. There's been some great comments to us in the chat, and I have a couple questions. Is it okay if I read them to you? All right, we'll start off. There's one here saying, are you seeing an increased demand for genetic testing in infants and toddlers? Are we looking at environmental influences?
Well, so that to me is a little bit of a difficult question. increased demand for genetic testing, I think, is happening because we are recognizing that chromosomal microarrays are valuable as a first step for our global developmental delays and for our kids with major and minor anomalies. And so I think that it is being increasingly performed in your NICUs and in your nurseries, as well as there is such an expansion of genetic testing that more is happening so that we can better help families. And the second part of the question, I forgot.
I did want to answer or help answer that part as well, which I've witnessed in you, Dr. Schmid. You are an expert in these areas. People are often surprised that one of our frequent referral reasons in genetics is the evaluation of child with fetal alcohol syndrome. So we often help families understand that and understand the effects of the exposure in the child. And we also sometimes help families understand other exposures, such as in babies that were exposed in the womb to gestational diabetes and elevated blood sugar levels.
So that second part was, are we looking for the added environmental influences? And I think that's what you were addressing there, Alexandra. Thank you. Did you want to comment on that, Dr. Schmid?
Well, as Alex said, that is certainly, if you've seen a genetic intake, it is a key piece of information that we hone in on, is understanding what happened in pregnancy, so that if there was a fever or there were rashes, if there was a car accident, if there were exposures to medications, uncontrolled diabetes, all of these will play in to how a fetus forms and develops. So it is an important part of our history.
Great, thank you for answering that. We have another one asking, what would you suggest for PCPs to do if their patient is hesitant in doing a genetic referral when there are clear indications, the rule of twos and twos, that the family needs the referral?
That is an excellent question. And so it is one that when I was a pediatrician, I would take a little extra time to address. And so I would say that I am concerned that I am seeing these differences. And I think it is important to have a person who has time to fully evaluate your child and your family to see if there is something that we need to further address. I think if the patient continues to be hesitant or no-shows their genetics appointment, that could be a time where you give us a call and we might make recommendations for, well, if the patient won't come to clinic, can you consider doing that kidney ultrasound? Can you consider doing the echocardiogram? Seeing if we can get even more information so that we can have more power behind our recommendation to see genetics.
Great, thank you for answering that. Alexandra, did you want to chime in at all?
Oftentimes when a patient comes to the genetics clinic, they don't know why they're there. And it is of no fault of the primary care provider. Coming to the genetics clinic is complex. It's very long. Our visits are typically 90 minutes to 2 hours long. And so families are surprised that we go over everything, just as Dr. Schmid was saying, the birth history, the developmental history, even the diet history. And so in the end, we never twist a patient's arm to do genetic testing. We explain to them that we're not a genetic test salesperson. We're just there to give them options. And it's always the family's option if they want to do the testing or not, or what their goals are from the visit.
Great, thank you for clarifying that. And we have another question. If 3 minor deformities are present, you stated to have a good cardiac exam, obtain a renal ultrasound, and a third item. What was that?
Sometimes I will do x-rays of the spine to see if I have any hemivertebra or any other anomalies that I would not pick up on physical exam.
Great, thank you. I think that's one of our clinics participating, so thanks for that. So thanks for that question. And is there anyone else that has, we have time probably for one last question. Is there anyone else? Oh, we have one more that popped up there. When would a microarray be requested?
Alex, would you like to?
Oh my gosh, there's so many reasons. It's hard for me to summarize them all, but I typically use microarrays when I'm picking up as a first tool if there are major and minor anomalies. I also use it frequently when I'm evaluating a child with autism or intellectual disability for the first time.
And I'm just going to pipe in and say that we did a lot of work in our last grant cycle with your colleague, Scott McLean, Dr. McLean, and he did a great webinar for us about microarrays and using microarrays. So I'm going to, it's part of our developmental delay algorithm for Mountain State. So I'm going to pop that in the chat if anybody would like to dig into that a little bit further. Great. Well, seeing no other questions, I think we can wrap up here unless you all would have any closing thoughts, Dr. Schmid and Alexandra.
So I just saw one question pop up, and it is a great question. When do you order the microarray? Are you going to order it as the primary care provider, or are you going to ask genetics or another subspecialist to do that? If you are comfortable in talking to your patient about what the microarray is looking for, and so I just simply explain we're looking at your chromosomes, which is your genetic information, and this is going to give me a big picture to understanding if all the pieces are present or if they are missing. And then if something is wrong or different about your chromosomes, then I can further explain or understand what is going on with your child. And then I also like to make sure parents recognize on the chromosomal microarray that with our technology, we may very well pick up familial relationships. So I am happy to see primary care providers ordering chromosomal microarrays, but I want you to feel comfortable when you get that report back that there might be something called areas of homozygosity, which might indicate that there's familial relationships between the parents, and just kind of judging for yourself if you feel comfortable discussing that information or if you would prefer for a genetics professional to do it. I would certainly empower you to order it for your global developmental delays, your autism, your major minor birth defects, but I think either way is good, just depending on your comfort level.
Great, thank you for answering that and seeing that pop up there in the chat. Last call for any other questions for our two guest speakers today. And I just want to thank you both again for your time and putting together this presentation, your creativity with the escape room and the twos and twos. Thank you for sharing that today. We really, really appreciate that. We are recording this presentation, as we mentioned, and we will be putting it on our website. If you would like to get notified when those are available, we put all those updates in our newsletter, our monthly newsletter, and I'm going to put that, I put it earlier in the chat, but there's a form you can fill out if you'd like to be added to our newsletter to get those updates. We just send them out once a month, but feel free to fill that out so it comes right into your inbox and you can get notified when those are up on our website. In the meantime, thank you again so much for joining us today. Thank you, Dr. Schmid and Alexandra, for your time and your expertise.
Our pleasure.
Thanks, everyone.
Bye. Take care.
Bye-bye.